Thank you, Dr. Fowler. So, good morning, everyone. My talk today is on MRI in pregnancy, both fetal and maternal, and I'll be talking about the practical considerations and some indications. We've divided the talk into CNS and non-CNS, and so I'll be showing some examples of fetal MRI for CNS indications. So when it comes to practical considerations, there are quite a few in pregnant patients. And these are the things that I'll be talking about. There are a lot of scanning issues. You, of course, have to consider safety of the MRI in pregnancy, and then when should the MRI be done? And of course, we'll talk about contrast, if it is indicated or not. So we know, the size of the population, especially in the US, has been increasing. You look at the graph, the chart, in 1970, 45% of the patients were considered obese. And you come to 2000 or 2020, and almost 74% of the population is considered obese. Now take that into factor, and also the fact that you have a pregnant patient whose size is going to keep increasing, she's going to gain weight, and you have a belly that's growing. Trying to fit that patient into an MR magnet, it's something like this, trying to fit the cartoon depicts that person being fit into a swimming tube. It's similar to that, trying to fit the patient into a magnet. So that's a consideration you have to think about when you think about scanning pregnant patients. You have a lot of options. You can use white bore magnets, the open MRIs. The open MRIs would not give you as good resolution. The white bore magnets may give you some leeway in being able to fit a patient into the magnet, but these have restrictions as well. Another issue that comes up is inability of the patient to lay flat, and that's because your fetus and the uterus with the fluid and placenta, it compresses on the IVC. So this is as if you're looking from down, up, down. And so you have your aorta and IVC, and then there's a lot of pressure when a patient is supine on the IVC, and once you compress the IVC, the venous return is hampered, and of course the patients don't feel well. We give a wedge behind the patient, so we elevate her right side and have her left side, or elevate her left side and have her right side down. So that way, the pressure on the IVC is lifted, and the patients feel much more relaxed and are able to lay on the MRI bed for a longer time. Other issues, long exam times. We know that you have to repeat sequences. You may not get the exact plane. You may not get the exact information. Maybe there's motion. Maybe there's motion from the mother. The mother might be breathing, and so you might need breath hold sequences. The fetus might be moving, and the fetus has these multiple types of motion. You can have bulk motion where the fetus does a somersault. Now, of course, you can't really anesthetize the fetus, though there have been instances where, in the past, where the fetus was anesthetized by injecting pancuronium into their muscle, into their thigh muscle. We don't do that. We don't anesthetize the fetus. We just hope that the baby lays still. So you have your bulk motion, you have your extremity motion. Of course, the baby is moving, and the baby is moving the hand and the and the limbs and the lower limb. Internal motion, like swallowing and breathing, of course, you can't stop that in a fetus as well. And so these are things to consider when doing a fetal MRI. Patients have altered anatomy. Now, with the uterus increasing in size, with the baby increasing in size, it does push structures superiorly, laterally. So a lot of the bowel loops get displaced. There's pressure on the liver, on the other organs. And so mainly things like small bowel and appendix gets pushed around. The ovaries move as well. The ovaries rise out of the pelvis into the abdomen. And so these are things that need to be considered when doing a fetal or maternal MRI. Now, the most important thing to think about in terms of safety is the specific absorption rate, or SAR. Now, SAR is basically the amount of heat that is deposited because of the radio frequency energy. And it increases with the field strength or the RF power, and of course, the coil type that you're using, comparing a body coil or a surface coil. When you go from 1.5 to 3T, the SAR increases almost 4 times. So there's not a doubling of SAR. There's it goes 4 times up. Now, your multi-echo, multi-slice sequences do create a higher specific absorption rate as well. Now, the International Electrotechnical Committee came up with some limits pertaining to the specific absorption rate in MRI, and FDA approved or accepted those limits. FDA doesn't set them themselves. FDA relies on the IEC. And these are the limits that they use. So for a whole body, for a 15-minute scanning, continuous scanning time, the SAR should not go over 4. For head, for a continuous scanning time of 10 minutes, should not go over 3.2. These limits are the absolute maxima, so you cannot go over these. And because the FDA doesn't define these operating mode, it relies on the IEC, and so IEC defines the normal and the first level operating modes. So what are these normal and first level? So for a normal operating mode, your whole body SAR is limited to 2 watts per kilogram. And for the head, it's about 3.2 watts per kilogram. For the first level that they call the first level, they would be at 4 and 3.2. So the normal mode is for any patient, can be used in pregnant patients as well, doesn't cause any stress in the patient or physiologic stress. The first level modes can be used under medical supervision. So our machines are limited to your normal operating mode. You can override those to the first level operating modes, but you have to go through a few steps to do that. So why are we worried about SAR? Because specific absorption rate, as we said, it leads to, you're worried about the heat deposition. It's the amount of heat deposited. Now, so we are worried about the temperature because it's not exactly SAR that we are worried about. We're worried about the temperature rise in the patient. And if you look at the normal operating mode, the limits set are a rise of 0.5 as maximum, or a maximum core temperature of 39 degrees Celsius. And the first level limit is set as 1 degree Celsius rise, or a maximum core temperature of 40 degrees Celsius. But temperature is really difficult to estimate. How do you estimate the temperature within a patient during the MRI sequence, or during a particular, in an animal during the MRI? So SAR is sort of a correlate that we use for temperature increase. Now, there are some studies that have looked at exposure to RF and their effects. So Edwards in 2003 did an extensive review of effect of heat on the embryos and the fetus. And they scanned these animal models at different time limits. They found that CNS was most vulnerable, as expected. And if there's an increase of 2 degrees Celsius over 2 hours, you would get neural tube defects and craniofacial defects in these animals. So the rules basically say that any pulse sequence that is developed must not cause a body temperature rise of greater than 0.5 for the normal mode or greater than 1 for the control mode. And there is an experimental mode as well. Again, we don't use that, where you can go over 1 degree Celsius. But again, that's only for experimental purposes and probably not used in humans, used in when you're doing these experiments on animal models. So the manufacturers set the SAR level for each pulse sequence, and that is what we get. This particular study from Han, they looked at the body coil at 1.5 T and 3 Tesla, and they found that the fetal SAR deposition was about 40 to 70% of the mom. So if the mom SAR is within limits, naturally the fetal SAR will be within limits as well. And so that's the reason why we are not worried about the specific absorption rate, as long as you follow the rules and regulations and don't override things. Now, in terms of acoustic issues, that's another concern that we have. It can potentially cause damage to the fetus. You give the mother earplugs, and that helps a little bit. But what do you do about the fetus? So you can see that the EPI sequences that we use are the loudest, and you can reach almost 120 decibels. 120 decibels is like a rock concert. And if you reach that level, does that cause harm in the fetus? So one of the things to remember is that the fetal noise, the noise that reaches the fetus, is not airborne noise. All these levels are for the airborne noise. You have fluid surrounding the fetus, and sound transmission through fluid is less compared to airborne noise. And the thing to be concerned is mechanical vibrations from the sound. And so there's insulation also from maternal fat. Abdominal wall, uterine wall, that can cause insulation and likely not damage the fetal ear, because you have all of these factors to consider. In 1994, this particular study looked at the effect of acoustic damage, and they had 18 patients in the study by Baker. They found that 16 passed 8-month hearing test. So with these, and you look at your, your magnets, all of these different magnets, the cylindrical magnets, open magnets, they did not reach levels above 120 decibels. And so it was concluded that the acoustic damage from MRI during pregnancy is more of a theoretical concern rather than the real one. And so that's why we're not concerned about it. How about 1.5T versus 3T? In terms of safety, you're worried about the static field exposure and the RF power deposition. And if you use gradient fields, you're rapidly switching, and that's of concern as well. But even though the SAR is 4 times, at the usual scanning protocol, your temperature doesn't rise greater than 38 degrees Celsius. And so you could use 3 Tesla. Of course, the issues are, fetal, the fluid, the amniotic fluid around the fetus can give you artifacts, and and that itself can perhaps hamper you from using 3 Tesla. We don't use 3 Tesla, and we didn't get good results with 3 Tesla. We use 1.5 Tesla, though there are centers that use 3 Tesla and get good results as well. In terms of timing, Yip et al. Looked at chick embryos at 1.5 Tesla at different times during their pregnancy, and they found that there was increased abnormalities in mortality in 6-day embryos. Now, we don't really scan 6-day embryos, and so that's something to consider. So what does the ACR say? So the ACR says that the pregnant patients can undergo MRI at any stage of pregnancy if you look at the risk-benefit ratio to the patient, and if if that warrants that an exam be done. So you can do an exam in patients who are in the first trimester as well. Though it is prudent to wait about 17 to 18 weeks, especially if you're looking at the fetus, because things are really small, and you may not get the resolution when you have a very small fetus that is moving around quite a bit. So we don't really do a fetal MRI before about 20 weeks or so in these patients. Now, what about contrast issues? Now, contrast, there's no known adverse effects in humans. There's no, but there are no controlled studies of teratogenic effects. We know that the gadolinium traverses the placenta, goes through the placenta, the fetus swallows it, the fetus swallows, gets through the gastrointestinal tract, the fetus then urinates it out into the amniotic fluid, and that can remain there indefinitely because the fetus sort of swallows the same amniotic fluid and it's processing it again. We know that the free gadolinium is toxic to the fetus and can cause NSF in the fetus and the mother, theoretically. So we don't really use gadolinium. If I'm asked to use gadolinium, if the risk-benefit ratio outweighs, is favorable for the mother, then I would use it, but only in really late gestational ages when I know that the fetus is probably going to be delivered in the next week or 2 or so. But otherwise, I wouldn't use gadolinium. So it is a Class C drug, and ACR says that each case should be reviewed carefully, and then you can use gadolinium only if the risk outweighs the benefit for the patient. The European Society has similar guidelines, smaller dose to be used, and very strong indication for gadolinium-enhanced MRI. What about long-term outcome? Patients are worried, what about 10 years down the line? Will we find something that happened because of the MRI? This particular study looked at 72 healthy women, scanned in the 2nd or 3rd trimester, and they followed them up using this VABS score, and they concluded that prenatal exposure to 1.5 Tesla, so it's important to remember, it's 1.5 Tesla, was not associated with disturbances in functional outcomes or hearing impairment. So those are practical considerations to think about in short. Now, looking at some of the indications, we'll talk about the maternal and fetal indications restricted only to CNS. Now, in terms of maternal indications, one of the commonest indications that we scan patients for is abdominal pain. And if you look at appendicitis, for example, you have a reported sensitivity of 100% and 94%. So this patient had appendicitis. You can see a rounded structure over here. It's blind ending. There's fat stranding around this particular structure here. So you can see the fat stranding is bright on the T2-weighted structures. We didn't need gadolinium in this patient, and this was appendicitis in a pregnant patient. Inflammatory bowel disease, really good exam to perform MRI instead of doing a CT and exposing the fetus to radiation. Sensitivity of 91%, specificity of almost 71% or so. Useful for diverticulitis as well, though you don't expect diverticulitis in this population since it's a younger population, but can be used. And these sensitivity specificities are reported in non-pregnant patients without contrast. There are multiple other indications that you can use it in, ovarian masses, pelvic pain, et cetera, et cetera. So MRI is really helpful because of the fact that it can give you multiplanar imaging and has no ionizing radiation. One of the indications that we've recently started using MRI in is pulmonary embolism. So we perform a non-contrast MRA in these patients using just the PLACENTA FP images. And these are the images that we get. And you can see the blood vessels quite well. And at least the central large pulmonary emboli can be easily seen in these patients. This particular study compared pulmonary MRI in pregnant and non-pregnant patients, and they found that there was no significant difference between these two groups, pregnant and non-pregnant. They used contrast in the non-pregnant patients, but still found no difference. And so I think this is something that we've started to use more and more in patients who come in with possibility of pulmonary embolism. In terms of morbidly adherent placenta, MRI is great, especially for posterior placentas, and when we have questions on ultrasound, we use multiplanar T2-weighted sequences in multiple planes. You can see that sensitivity, specificity is good, though some cases, in some papers, specificity has been quite low as well. And what do we see in MRI of the placenta? In early gestational ages, so 20 weeks, 22 weeks, you can see that the placenta is quite uniform. So uniform looking placenta, you can see the myometrium as high signal intensity structure adjacent to the placenta, and you can see the difference between the myometrium and the placenta and the interface pretty well as well. But older gestational ages, beyond 32 weeks, we believe that there's heterogeneity in the placenta. So you start seeing these little bands and little cotyledons that form. And so you see these thin cotyledon sort of structures forming. And then it becomes difficult to evaluate the MR. And the reason being because when you look at morbidly adherent placenta, you get placental heterogeneity. So this is what you're looking for, placental heterogeneity. We can see that in older placentas. You get these dark intraplacental bands, which we're not really sure what that corresponds to, perhaps vasculature, but that is a feature that has been described with MAP. You get placental bulges, so you can see these focal bulges. Of course, patients with placenta previa, prior C-sections are at higher risk. And then you can also get this disruption of the interface. We saw a really good interface on the normal patient, but you can't really make out that interface over here. And then, of course, you get increased vascularity as well. So these are the features that you look for in placental invasion. Now, in terms of fetal imaging, we know that it should be used as an adjunct to ultrasound. And why? Because as the babies grow older, you get a lot of artifacts. You have reverberation artifacts on ultrasound. It's difficult to penetrate through the skull. If you have oligohydramnios, it's difficult to see the structures. And that's where MRI is helpful. It has better contrast resolution, large field of view. You can get true multiplanar images. And we use it to confirm the diagnosis or offer alternative diagnosis. Patient counseling, that's a big one. Our pediatricians understand MR much better, and they can help counsel the patient with these images. This particular study from Santos looked at, what are the indications? So they found CNS was the most common indication, and then lung and thoracic cavity was the second most commonest indication. And they found that in almost 40% of the cases, it was concordant, but in almost 40%, there were either additional findings or it changed completely. So MRI is very helpful. This is a case in point. This is a patient who had hydrocephalus. You can see that it's very difficult to see intracranial structures because of the older gestational age. When we did an MRI, actually, so we saw the hydrocephalus, you can see the colpocephaly, absent corpus callosum. This was not seen on ultrasound. So the absent corpus callosum was the diagnosis in this particular patient, not seen on MRI, very helpful to counsel the patient. Another case, this is an only non-CNS case that I have. Patient came in with shifted heart to into the left side, little bit of pericardial effusion. So we suggested an MRI. And what did we see on MRI? There was right-sided diaphragmatic hernia. This was not picked up on ultrasound. We saw this on MRI, and this changed the management completely because it was not just a simple pericardial effusion. It was actually a diaphragmatic hernia. And you can see this is post-delivery radiograph. You can see bowel loops up in the right side of the chest. So very helpful in CNS imaging, especially in ventricular megaly and posterior fossa evaluation. Deborah Levine found that they found a change in diagnosis in almost 40% of cases. This particular study found additional information in 60% of cases. You have to remember that the fetal brain is changing over the gestational ages. So at younger gestational age, a very smooth brain, but as you go further, you see the sulcation and gyration develop. Here's another case. Patient came in with hydrocephalus, pretty bad hydrocephalus. This patient actually had, this is a different patient, had aqueductal stenosis. So you could see the third ventricle dilated as well. Posterior fossa was normal. Another patient with Dandy Walker variant malformation. You can see the posterior fossa really well compared to what you see here. Cerebellum is dysplastic, no wormus. Encephalocele, we use these, and we use MRI quite commonly to see the contents of this encephalocele. This is a beautiful case with, which illustrates why MRI is helpful. This patient came in with hydrocephalus, didn't really know the reason why, was referred from outside. We thought maybe there's something in the posterior fossa, because this looked very heterogeneous. Did an MRI, and lo and behold, we found a posterior fossa teratoma, because this is a large mass in the posterior fossa, very irregular, had some areas of hemorrhage. There's actually, there was compression or downward pulling of this mass into the spinal canal as well, and we gave that information to the pediatricians. So this was a posterior fossa teratoma. Baby was delivered and then scanned, and you could see the teratoma again, areas of hemorrhage, and a lot of hydrocephalus. Unfortunately, baby died, and you can see that even on the pathology pictures, you can see part of the cerebellum being normal, but a large tumor developing in the posterior fossa. So this was really helpful for management. Then we have another patient who came in with hydrocephalus. So you can see the hydrocephalus here, and we were wondering, what's going on? Is there a choroid plexus tumor over here? Because this choroid plexus looks very heterogeneous. Did an MRI, and we found that there was hemorrhage. So there's hemorrhage in that ventricle. She was referred in only as newly developing hydrocephalus. This changed management because we said, well, maybe this could be neonatal alloimmune thrombocytopenia. Patient, they did a percutaneous umbilical blood sampling, decided to transfuse the patient, and postnatal images show that there was hemorrhage intracranially, prenatally, and the lasting effects of that particular hemorrhage as well, seen here with cortical thinning. So in terms of spine, useful for sacrococcygeal teratomas, you can see the intra-abdominal contents of the teratoma much better. This is a case in point as well. Patient was sent in, had a mass in the spinal canal, not really sure what it was. There was some vascularity. We said AVM, could be a lipoma as well. Did an MRI, bright areas on T1 weighted images. You could see the mass over here. And then postnatally, it was a large lipoma in that in the spinal canal that we were able to give the diagnosis on prenatal images. So I'm going to stop over here. I think fetal MRI is really helpful, but there are safety considerations that you need to look at, and we've discussed some of those. And if you use contrast, I would recommend not using contrast in early gestational ages, only in later gestational ages. Thank you very much.